You are not going to want to go to sleep during this show, but you may sleep better after watching it. A Norwalk Hospital sleep expert, Dr. Christopher Manfredi, is our guest, and he'll discuss insomnia and its treatments. So stay tuned for an important and informative show. Health Talk is up next. Hello, I'm Dr. Eric Mazer. Welcome to this week's Health Talk. Today we're going to talk about insomnia, a very common sleep disorder. My guest is Dr. Chris Manfredi, who specializes in pulmonary critical care and sleep medicine. Welcome to Health Talk, Chris. It's great to have you back.
Well, thanks for having me back.
I always look forward to this show because sleep is it's something we all do.
Everybody has to, yeah.
And it's obviously important. Let me just start off. Do we understand sleep any better? Why we all need sleep so desperately?
Probably one of the bigger questions that's not completely answered, but it certainly serves a restorative process. It's during sleep where our memories get consolidated. Certainly serves a biologic function in terms of how your hormones are released and repairs the body during sleep. But in terms of the actual details, why we dream, those kind of things, there's a lot of conjecture.
It's really sort of an amazing thing. We spend a third of our life doing it, and we really just have some general ideas about what it's doing. And why sleep disorders are pretty common. How prominent is the problem with insomnia?
Some types of sleep disorders in general are very common. The most common sleep disorder actually being the technical term is behaviorally induced insufficient sleep. Most Americans are not getting enough sleep because of their behaviors, not because of insomnia or sleep apnea. But in terms of insomnia, probably at some point or another, 30% of the population will have some bout of insomnia.
Quite a hunk of it.
For sleep apnea, it's probably somewhere in the neighborhood of 5 to 8%, depending on how you want to look at it.
Well, looking at insomnia, how do we define it? Everybody has trouble now and then going to sleep.
Yeah, insomnia is, the type of insomnia where, it's a problem is exactly that. Like if you're having either the perception that you're having trouble falling asleep or maintaining sleep, or the perception that you have unrefreshing sleep, that's more of a chronic problem, and you find that it's bothering you or affecting your life.
So sort of the cutoff is where the fatigue or the problem sleeping actually interferes with your daily activities?
Either interferes with your daily activity or, and this gets a little subtle, like if you feel that it is.
I see. So just simply the sense that it's interfering.
Yes.
Now, again, you've been through internship. I've been through internship. This is the old days. We used to work all night, all the next day. We lived on coffee.
The days of the giants. Yeah.
Yeah, the giants. It shrunk us down to size.
Yeah.
But what were we doing then? It was I know that I was sleep deprived for at least a year during my internship.
We were all very sleep deprived. We just didn't appreciate it. And it's interesting because we did a study before these new rules about all the hours that the residents work, and we did a study trying to show what would happen when people are sleep deprived, like the residents, and we did this psychomotor vigilance testing for post-call residents versus regular people, and what we found that the residents actually didn't perform any worse than people who had enough sleep. And I think what we discovered is that, which was partly known already, is that you cannot learn to function without sleep. You either genetically program that you do better without it than someone else, and people who go into our field, like the idea of staying up all night didn't scare us off, so we were okay with it. Other people said
it scared me, but I lived it.
Yeah, we all did it, but so everybody has a threshold of how well they function without sleep. And
does coffee help? We also use caffeine.
Caffeine, absolutely.
What does that do?
In terms of sleep deprivation, and in terms of helping you, there's a very scientific basis for caffeine, and in certain people, especially people who do shift works, I actually suggest caffeine at certain parts of the day, people with narcolepsy. There is a chemical in our brain called adenosine, and that adenosine, you can actually measure it in the early morning. It's a very low level. As you go through the day, the level of adenosine goes up, and you can correlate that level of adenosine with how sleepy people feel. And caffeine is actually a blocker of adenosine, so it blunts that effect on the brain that's telling you want to go to sleep.
So could you use coffee, if you're have insomnia and you're not getting it, can you use coffee sort of
Well,
indefinitely and as much as you want?
In most cases, and there's a lot of nuance to it, and there's a lot of individual things, but in most cases, if you feel that you're not sleeping, caffeine is not something I would prescribe or recommend in that circumstance, because the effects of caffeine can follow a different sort of kinetics in people who have insomnia than a regular person. So generally when people have insomnia, we recommend avoiding the caffeine till we can get the sleep back.
So let's talk about insomnia. Causes, how do you approach that? Someone comes into your office and said, I'm not sleeping well.
So the first thing we want to do, the first thing we decide when I see someone for an insomnia consult is, does there seem to be something underlying the insomnia, and the most common thing would be sleep apnea. For me, clinically, there's a big difference if you have insomnia, whether you feel like you can't fall asleep or stay asleep, and you don't feel sleepy during the daytime, versus having that same complaint and you feel sleepy during the daytime. People who have insomnia and feel sleepy during the daytime are more likely to maybe have something underlying in their sleep that may be driving the insomnia. Whereas, and again, I'm generalizing, but people who have sort of garden variety insomnia, often that's related to stressors at work, maybe stressors even in their past, habits that they've gotten into, and that's much more of a behavioral evaluation and treatment. Whereas if you have something underlying the insomnia like sleep apnea, then that's a whole different treatment path.
That people are learning a lot more about that because of all the advertisements on TV.
Right.
So what should the average person do? When do you start to realize it's a problem?
I would say
how do I go to sleep better?
What I strongly recommend, everyone sees me, is right off the bat, if you have insomnia, do not search for the answer in a pill. This is a bad pathway. This is not likely to solve the problem, and this is very likely to get you into more of a downward spiral. You have to analyze what's going on, but basically, some general rules. It's very, very important to have a regular bedtime and a regular wake time when you're having this insomnia. And one of the most common things I see is people will try to get more time in bed because they feel like they're not sleeping, and it actually magnifies the problem. So when you're having insomnia, you should be spending less time in bed, not more time in bed.
It seems paradoxical.
It's paradoxical, but your brain needs to know when it's time to sleep. So if you keep going to bed earlier and your brain's not ready to sleep, you're just going to have more insomnia, which is going to get you more aggravated. So you're going to be more excited, so less likely to fall asleep, and it's just going to exacerbate the problem.
Yeah, and I know I've had a period of insomnia during and it's funny, I would feel tired at 8:30 or 9 o'clock in the evening, but then as I was approaching my bedtime, I'd wake up as I knew I was going to be trying to fall asleep. I became hypervigilant. I became hyper alert.
Because that's what I'm saying, because it's people with insomnia often will say, I can't fall asleep, but meanwhile, 3 hours earlier, if they were watching TV, they fall asleep. Well, they fall asleep because they're not thinking about sleep. It's not getting them excited. It's not getting them aggravated. When you have insomnia, and especially if it's been going on for a while, just the thought of going to bed starts to create this anxiety and this thought process, and the act of going to sleep winds up having way too many moving parts.
Yeah, and I must say, having suffered with that, it can be quite distressing.
Absolutely, and it magnifies.
As you said, it tends the cause literally magnifies itself.
And sometimes, there can be something that precipitated it that the patient may not even recognize. But even if that precipitating cause goes away,
the behavioral pattern is already
the pattern gets established, and it's hard to break out of it. So
let me just go back to the pills. You mentioned you don't want we've read recently about some of the bad effects of some of the sleeping pills, the autonomous behaviors and things. But they're also quite effective, some of them.
Well,
what's wrong with them?
They're not as effective as you think they are, right? So let's step back. Not just sleepwalking and potentially dangerous things, and especially in older people, more issues with sleeping pills, falling down, break your hip, those kind of things. But there's been 2 studies now, one by the American Cancer Society and one that was independently done years later, which has found a signal, and you know what that means, like we're not sure cause and effect, where in people who take sleep aids to go to sleep, and it doesn't matter which type they take, there's a higher risk of cancers. So I think that's something that people should be aware of. We don't know about the cause and effect, but the more important thing is your doctor should be able to help you get to sleep without the pill. There must be sleeping is a natural process. You shouldn't need help with it. You shouldn't need a pill. You don't need a pill to tell you it's time to eat lunch or time to eat dinner. These are natural functions. So if we...
No, I need the pill to tell me to stop eating.
Right, exactly. So I think that once you get on those medications, you get dependent on them, it actually can make the insomnia worse in the long run when you're trying to
and some of the sleep is not quite the same sleep, is it?
And I will tell you that if you actually look at the data, you know, the average person falls asleep in like 15 minutes, let's say normal people. If you actually look at the data of one of the most commonly prescribed sleep aids, when you look at the studies which made it FDA approved, people on average fell asleep 5 minutes faster than without it, which is 30% faster. Like, so it's approved, but it's really not a huge difference, and there is, and patients who are on these medications often bristle when I tell them this, but there's a huge placebo effect on those medications.
I absolutely believe that. We only have 2 minutes left, believe it or not. I know that the American College of Physicians and others now say the first approach to insomnia is behavioral and cognitive therapy. Give us a sense in a couple of minutes of what that
cognitive behavioral
because it
therapy,
all sounds like a little bit of hocus pocus.
It's not at all. Cognitive behavioral therapy is very practical. It's very commonsensical. It's not medication. It will last you a lifetime. It has to do with some of the things we touched upon. What time do you go to bed, the times you get up, your thought process of what you feel like when you're going to sleep. This concept that, okay, if you wake up at nighttime, you shouldn't stress about it. When I wake up at 3 o'clock in the morning, I'm just glad it's not 6 o'clock so I can go back to sleep. When people with insomnia
I'm glad just to wake up.
Right. When people with insomnia wake up at 3 o'clock in the morning, their brain starts, oh, here we go again, I'm awake, and it sets up this stress response, which makes it harder to fall back asleep. So cognitive behavioral therapy is in a sense, managing cognitive, the way you think about those things, and behavioral. Don't get into bed too early. Don't drink caffeine after noon, depending on the person. If you haven't slept all night, you can't just stay in bed till 10 o'clock. It's just going to make the problem perpetuate for the next night.
And I'd like to say, again, we're running out of time. It works. I'll say from personal experience, things like meditation, focusing your thoughts on relaxing events.
All those
things can really help you.
All those things can work. They can work better than medications without the side effects, and then really actually put you back to yourself sleeping, being a self-contained sleeping unit.
And I'd like to point out again, is that this isn't something you go home and you say, okay, today I'm going to do meditation. You try it that night and it doesn't work. You say, oh, God, it didn't work for me. No. You almost have to teach yourself and learn it, don't you?
It's a process, and it's like anything else. Depending on how long the insomnia has been going on for, it's going to take a corresponding amount of time to get you out of that cycle.
And we've run out of time, but I think this is really important for people at home, that there are ways to help. It takes some time. You've got to learn it. Work with a skilled physician.
It doesn't have to be a physician, but it could be. There are a lot of sleep therapists out there who do this kind of work.
Who know what they're doing.
Who specialize in sleep. There are behavioral sleep medicine specialists. There are online programs for cognitive behavioral therapy for insomnia.
And this stuff works, so please, if you're at home, don't give up.
And this is one of those times where I would say that online help is actually helpful, can be helpful.
And unfortunately, we are out of time. I want to thank my guest, Dr. Chris Manfredi, for joining me on Health Talk today. Please share your questions and comments with us by calling Community Relations at Nuvance Health, 203-852-2250. I'll see you next time.
Well, Thomas, you've got prediabetes. But with more exercise and a change in diet, it can be reversed.
I've tried exercising. It just makes me hungry for bacon.
I love bacon, too. And who really likes to exercise?
Not me.
Me neither.
Nobody. So we're good?
What? Oh, you still have prediabetes. big time.
When I was 6, my days were spent playing basketball every chance I could. When I was 6, my dream was to make it to the NBA. When I was 6, my mom had a stroke.
I'm Paul George, and I want you to learn the signs of a stroke fast. F-A-S-T.
F, face drooping. A, arm weakness. S, speech difficulty. T, time to call 911. Because the sooner they get to the hospital, the sooner they'll get treatment. And that can make a remarkable difference in their recovery.
Protect the ones you love.
Spot a stroke, F-A-S-T, fast.
According to the National Sleep Association, 18 million adults have sleep apnea. This is a condition that can be potentially serious since breathing is repeatedly interrupted during sleep. On this week's Health Talk, we're going to discuss the causes, symptoms, and treatments for sleep apnea, a very common sleep disorder. So stay tuned for an informative show. Health Talk is up next. Hello, I'm Dr. Eric Mazer. Welcome to this week's Health Talk. Today we're going to talk about sleep apnea. My guest is Dr. Christopher Manfredi, who specializes in pulmonary and critical care medicine, including sleep medicine at Norwalk Hospital. Welcome back to Health Talk, Chris.
Well, thank you for having me back.
Sleep apnea, I guess there are so many commercials about it now that most people know what it is, but you want to
would
review
think,
that a couple
yeah,
times?
I mean, the commercials are more for cleaning stuff,
Yes.
but sleep apnea is a very common illness, like you said. It affects probably 5 to 8% of the population, which is similar to diabetes and high blood pressure and asthma. And it can have some serious health consequences, not just feeling tired during the daytime, but increased risk of high blood pressure, strokes, heart attack, weight gain, cognitive decline in older people. So there's a lot of health risks associated with untreated sleep apnea.
And what causes sleep apnea? Why would you stop breathing?
Well, sleep apnea doesn't necessarily mean you have stopped breathing, although you could, but it also can mean just decreases in your breathing. That's just not enough to maintain your oxygen and your carbon dioxide levels. But it's usually caused by a collapse to some degree or another of some part of your upper airway, often more than one part. And so the airway when the brain falls asleep, the airway collapses.
Because they relax, the muscles.
Because the muscles and the airway, the tissue relaxes, and then it can cause a decrease in the oxygen and an increase in the carbon dioxide. The brain senses this, wakes up out of sleep, opens up the airway, restores those levels, brain falls back asleep, cycle repeats itself.
So this is a way you're not going through the normal cycles of sleep, but you're repeatedly awakened as you start to go into a deeper sleep.
Your sleep is fragmented. It's not necessarily deeper sleep. Sleep apnea can occur, it doesn't actually occur that much during deep sleep, but it may occur more during dream sleep. So people with sleep apnea are also usually have much shorter amounts of REM sleep because the sleep apnea gets much worse during that stage of sleep.
And that's important as part of the restorative process.
Yeah,
isn't it?
all the stages of sleep are like food groups. There's not one any better than the other. 50% of the night should be light sleep, 25% should be deep sleep, 25% REM sleep.
So Chris, we always hear a lot about snoring and sleep apnea. Men snore more than women. I think we tend to, it seems like every woman I talk to is chased out of her bedroom by her husband.
Yeah, I mean, men snore more than women. Snoring in and of itself is not a disorder per se, but it should be a signal to ask more questions. So if you have snoring and any other thing that could go with sleep apnea, such as feeling tired during the daytime, feeling unrefreshed, having a history of high blood pressure or cardiovascular disease, having a neck size as a man that's 17 inches,
Oh, that's the threshold?
That's a threshold where the risk of sleep apnea goes up. You can certainly have sleep apnea with a lower neck size, but
I squeeze in there at 16 and a half.
That's 17. I don't mean 17 inch shirt, but actually measurement of 17,
really?
yeah. At 17, the risk of sleep apnea starts to go up significantly, but it doesn't mean that if you're below that you don't have sleep apnea.
So the sort of phenotype, the short squat neck is something that is real in terms of the risk of
It
sleep
is
apnea?
for the type of sleep apnea we see commonly in Norwalk, let's say, but
Obesity part of that too?
obesity is certainly a factor, and as you get heavier, especially a body mass index of 35 or more is certainly a risk factor for sleep apnea, though you could be perfectly thin. And people, and just to that end, there's a very high prevalence of sleep apnea in Asian people, and mostly they're not overweight, and it has just to do with the way the upper airway anatomy is constructed.
So the people should begin to think about this if they're snoring and one of those other things that you said.
Snoring and
fatigue during the day.
Unfortunately, the and might not come from the patient. The and might come from the spouse, because the patients will often not recognize sleepiness. That's very common, where a spouse will say, I'll say to the patient, "Are you sleepy?" And the patient will say no, and the spouse will go, "What?" And their interpretation of it is different. So sometimes we have to have a very very broad net to capture people to make the diagnosis, because a lot of people don't realize that they feel as bad as they do.
And maybe briefly, how do you make the diagnosis? Go through some of the procedures that you
basically, we do a sleep test, partly depending on your symptoms, and partly, and unfortunately, largely based on insurance preferences. There's a home test versus an in-lab test. The home test is pretty simple. The downside to the home testing is it can't reliably say you don't have sleep apnea. So if the home test is negative, you will need to do the regular traditional test we sleep in the sleep center.
So it says if you do it, it may or may not pick it up.
If you have a home test and it shows you have sleep apnea, you have sleep apnea. If the home test is negative, there's still an 18% chance you have sleep apnea, and usually we're going to proceed to do the more traditional test.
And this is where you come into the hospital and you spend a night there?
Come into the sleep center, not the hospital.
Okay.
Yeah.
And they wire you up and they measure a whole bunch of things.
We monitor the brain waves, so we know what stage of sleep you're in. We monitor your breathing. We monitor heart rhythms, breathing patterns. So the sleep center, as you know, is like a little hotel room. It's not in the hospital.
Yeah.
There we have there's soundproof rooms, your own bathroom, shower, TV.
I mean, as someone who's contemplated that, I can't imagine falling asleep in that environment. I'm sure a lot of people say that same thing to you.
A lot of people say that, but the truth is most of the people that we're studying in that environment are coming to me because they're sleepy, number one, so usually they can sleep. Number two is, I don't need 8 hours of sleep, so most people are on average, people sleep 5 or 6 hours at least, and that's usually enough time to make a determination.
Okay. Then it's not a painful test in any way.
No, it's.
So these are all external things.
Go to sleep. I mean, I've had worse tests than that. Beats a colonoscopy.
Well, they put you to sleep.
Yeah, exactly. Yeah.
This time you got to fall asleep on your own. So you've got this problem where you're maybe say a couple of why it is a problem. Why is sleep apnea a disorder that we should be conscious of and treat?
Right. For the things we sort of talked about a little bit briefly is, there's cardiovascular risks associated with sleep apnea.
It puts stress on your heart to stop breathing.
A higher risk of high blood pressure, strokes, heart attacks. In very severe cases, actually shorter lifespan.
Yeah.
Higher risk of motor vehicle accidents, weight gain. There may be issues with blood sugar metabolism. So there's a lot of cardiometabolic things that go along.
And I
with
think we're understanding too that there really is a relationship between sleep and weight gain. I'm reading more and more about that.
That's not just with sleep apnea, but even
I understand that.
Just even we talked about it earlier about residency and being awake. So sleep deprivation of any cause will cause you to eat more calories, and probably based on leptin resistance, leptin being the hormone that tells us that we've had enough to eat. Well, you start to become insensitive to that, and you actually will eat more if you're sleep deprived. And so people who are sleep deprived will gain weight.
So what a wonderful thought is, if you want to go on a diet, get better sleep.
Get better sleep. Yeah. Get more sleep.
Yeah.
More sleep, if you're sleep deprived to begin with.
Now, Chris, once you make the diagnosis, the treatments are mechanical, right? Generally.
Not all. So the Cpap is the most common treatment, and that's a mask that you use, goes over your nose, sometimes over your nose and mouth, and it's the device taking air from the room. It's not oxygen, just supplementing your breathing just enough to keep the airway from collapsing down. So that's a
So there's a
mechanical
little pressure in the extra pressure in the
Yeah,
mask.
there's some back pressure that keeps the airway from being able to collapse down when you're exhaling. The other mechanical device is an oral appliance which moves your jaw forward. And that by moving your jaw forward, it opens up the airway in the back.
In the back of your tongue, and I guess your epiglottis. You move that further.
Well, you move the tongue base and the jaw forward to just open up that airway,
bit more space
just a
back
little
there.
bit more space. There are surgeries that can be done, although they are only curative about 20 or 30% of the time. There is a new device on the market, or there's two of them actually, which is called a hypoglossal nerve stimulator, which is relatively new in the last few years, where they implant this device under your skin and attach it to a nerve in your neck and a nerve in your chest. And basically, when you turn it on when you go to sleep, and when you are breathing in, it moves your tongue forward.
that's
Yeah.
that's amazing.
But it's actually
real cyborg stuff.
it's actually fairly effective in the right person.
So this is implanted under the skin.
Yeah, like a pacemaker almost. And you turn the remote on, and when you go to sleep, and it senses when you're breathing in, it'll move the tongue forward, and then when you're not breathing in, it relaxes.
Wow. And what is, if you turn it on when you're awake? What does it feel like? You're not sticking out your tongue every 30 seconds.
Yeah, you would move the tongue, but I haven't had anybody have that yet, so I don't know. Yeah.
Well, that's really interesting. So this is.
But it's a tremendously
This is
expensive.
the technology of the future coming along.
Although I will tell you, there was just in the last 2 years, there was just a pilot study of, I didn't think I would see this in my lifetime, of a medication to treat sleep apnea. It was only 20 patients, but it looked very promising. So
How does that work?
it actually works by stimulating those muscles in the upper
Increasing
airway.
muscle tone,
In the upper-
just locally there.
In the upper airway, yeah.
Wow, that's really.
Yeah. And it was at Brigham's. It was not at,
Do you see that as a potentially future therapeutic?
I would have, a year and a half ago, I would have said never. There's no way that could work. But the numbers were, granted, it was only 20 people, but it was very promising numbers.
So, what are other clues? I mean, I've heard that people ask the spouse or the bed partner, does the person stop breathing, seem to stop breathing and then struggle? How useful are those historical
Well,
clues?
I think they're useful positive predictors. So if the spouse thinks you stop breathing, then the likelihood that you have sleep apnea goes up. But if the spouse doesn't see that, it doesn't matter. I mean, you still could have it. Actually, one of the most sensitive questions you can ask is, has anyone ever given you the elbow because of your snoring? And that turns out that if I don't ask you any other question, if I just say, has anyone given you the elbow because of the snoring, there's a very high predictive value of that.
Really?
Yes.
Just
that single question alone. Yeah.
Because I elbow my wife all the time.
There you go.
So, and what's changing in this? This is a disorder that I say 30 years ago I never heard a thing about it, and now it's so prevalent.
Well,
Where do
it
you
was
see
always prevalent. It just wasn't.
You just didn't understand
You
it.
just didn't understand it. Yeah. I mean, I think.
Where do you see this whole field going?
I think where I think the field needs to go is, it's so prevalent that it makes you wonder: is everyone we diagnose with sleep apnea, is that actually a disorder? Like, does everybody need to be treated the same? And right now we only have this broad brush where we relatively treat everybody similarly. I think where the future's going is, can we define who is at most risk for not having treatment for those things we talked about, and who is not?
That's very interesting, because I always wonder about any disorder that's so prevalent in the population.
Right.
You'd think it would be, what's the word? We would have evolved out of it if it was that dangerous.
It was that dangerous, exactly. So people who do this type of research really need to define, who out of all the people we're diagnosing have the most risk. You come and see me.
We have to run out of time, Chris. It's a really interesting topic. I'd love to pursue that. I want to thank Dr. Christopher Manfredi for joining me on Health Talk. And please, at home, please share your questions and comments with us. Please call Community Relations at Nuvance Health at 203-852-2250. I'd love to hear from you, hear what you want to hear about so we can put it on TV. We'll see you next time.
spot a stroke F-A-S-T, fast.